Very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on acute coronary syndrome. I'm thankful to all the participants from all over the country who have taken out their valuable time and are attending this evening talk. Pharm D Community has been created with the charter to provide webinars by doctors and family doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate, and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my core committee members. Thank you, everybody. It's my pleasure to release the flyer for our next webinar. The link will be posted in the chat box for both, that is Zoom and YouTube. It's on 30th of October. I'm thankful to our speaker for today, who is one of India's eminent cardiologists. So thank you, Dr. Nishith Chandra, sir. I'll hand over the session to my teammate Vaishnavi to introduce our speaker for today evening.
Thank you, Aishwarya. I would like to welcome all our attendees once again for the webinar. I'm glad to introduce our eminent speaker, Dr. Nishith Chandra, sir. Sir has done his MBBS, MD and DM in cardiology from King George Medical College, Lucknow. He is Director of Coronary Imaging and in charge of Air Ambulance Unit. Sir is former Director and Head of Department of Cardiology at Fortis Hospital, Noida. Editorial Advisory Board, Indian Clinical Update Handbooks, Hypertension by Wiley Blackwell. Sir is currently working as Director of Interventional Cardiologist at Escort Heart Institute, New Delhi for last 26 years. Sir also holds various memberships including Cardiology Society of India, Society of Critical Care Medicine, USA, Indian Society of Critical Care Medicine, Fellow of Society of Coronary Angiography and Interventions, USA, Fellow of European Society of Cardiology, Fellow of American College of Cardiology, USA. With this brief profile, I would like to welcome Dr. Nishith Chandra, sir. I hereby hand over the session to you, sir.
So, good evening, friends. Thank you, Aishwarya. Thank you, Vaishnavi, for a great introduction. And so this evening, what I shall be discussing is a very hot news, and you must have heard of that yesterday, the legendary cricketer Kapil Dev has undergone an angioplasty after a heart attack at our hospital, Fortis Escort Heart Institute and Research Center. So you must be wondering how a legendary cricketer or a sports person how can he have an acute coronary syndrome? So it is as a doctor, as a pharmacist, it is our duty and that we should understand the basic pathophysiology, the sign and symptoms, and the treatment of acute coronary syndrome. Because in medicine, it is the cardiology in which the time is very important. Every moment costs money, every moment costs health. So we have to be very, very quick in our decision making and diagnosis and treatment. So let me start by showing you this picture. This is the King George's Medical College, Lucknow, from where I did my MBBS, MD and DM. I entered this medical college in 1981 and passed out with DM degree in 1994. After that, I joined in 94. I joined the Fortis Escorts Heart Institute, New Delhi. And since then, since last 26 years, I am working at Fortis Escorts Heart Institute, New Delhi. So today, I'll be discussing acute coronary syndrome. I'll be taking you through the pathophysiology, how to diagnose. Once you have diagnosed, how to start the therapy. Should we do an angioplasty or should we do medical management? So how should we decide about and what should we do once we send the patient home? So these are the headings under which I would discuss today's topic. So as you have heard about the heading is acute coronary syndrome. Now, whenever the term syndrome comes, that means it is a conglomeration of 2 or 3 or more entities. So acute coronary syndrome basically entails, on the one hand, unstable angina, and on the other hand, ST elevation MI. And in between, there is a non-ST elevation MI. So what is the difference? Difference is, if you see, this is a coronary artery. These are the coronary arteries in cross section. If the coronary artery is totally clogged, totally blocked, 100% blocked with the clot, then it causes ST elevation MI. If it is partially blocked, then it causes non-ST elevation MI. Non-ST elevation MI, it also can be unstable angina when there is no release of cardiac enzymes in the blood. So on the one extreme, the milder form is unstable angina, while on the other extreme, it is the ST elevation MI, which has the worst prognosis. So how do we diagnose? This is, you can see the ECG of non-ST elevation. This is the ST segment. So in non-ST elevation, there is a ST segment depression. You can see the depression here, you can see the depression here, right? However, in ST elevation MI, you can see that this ST segment is elevated. This is the baseline, and from baseline, this is elevated. So the pathophysiologically, the ST elevation MI, there is occurs because of total complete occlusion of the coronary artery, while the non-ST elevation MI or unstable angina occurs because of the subtotal or partial blockage of the coronary arteries. Now this pathophysiological aspect you have to understand very clearly, because in ST elevation MI, the artery is fully blocked. That is the reason the person can die if it is not opened immediately through medicines or through balloon angioplasty, or unlike non-ST elevation MI, where there is a flow of the blood, partial flow of the blood. So it is the ST elevation MI where you don't have to waste any time, any moment. You don't have to waste a second. You have to immediately diagnose and start treating the patient. So let me start with the pathophysiology. Now, as you must be knowing that there are 3 main coronary arteries which run on the surface of the heart. So now if this is the myocardium, this is the coronary artery, and this is a normal coronary artery. You can see it is clean, absolutely clean coronary artery. What happens if we cut a cross section? You must be knowing through their pathological classes that all arteries have 3 layers: the intima, the innermost, the media, and the adventitia. The intima, the media, and adventitia. So if we take a cross section and look under the microscope, you can see like this. This is the lumen. This is one layer intima. This is media, and this is adventitia. If we see the same artery under the electron microscope, you can see this white thing is intima, single layer. This brown thing is media. It is made up of smooth muscles. And then this is adventitia. So intima, media, and adventitia. So how does acute coronary syndrome start? The ACS, acute coronary syndrome, starts with the injury to this endothelial lining. Now, this is the innermost lining which separates the circulating blood from coming into contact with the media. So, whenever there is a breach in endothelial lining, then the cascade of acute coronary syndrome starts. So, This process of atherosclerosis, it doesn't start instantly in the adulthood or late old age. It starts as early as the first decade of the life, as early as 2 years, or when the child is 2 years old. So that is the reason that we should advise right from the childhood that the person should take proper healthy lifestyle. He should exercise, he should not take too much of fatty food, he should not gain weight, he should not be smoking, because the process of atherosclerosis or the plaque buildup starts as early as 2 years of the life. So then how it starts? When this is the endothelium and we are seeing it under the electron microscope, when there is an injury to endothelial lining, then the body's defense mechanism starts into play. Whenever there is an injury, so body starts to plug that injury. So it sends it first line of defense, which is macrophages. So this is an injured endothelium lining, and this is exposing the underlying media. So it sends its first line of soldiers, which is macrophages. These are the macrophages. And what they do is they form a pseudopodia, which is amoeba-like structure, and it starts to scan the endothelium for any breach. And wherever there is a breach, they go inside, underlying the endothelium, and they form the first pathology of atherosclerotic plaque, the earliest pathology, which is called fatty streak. Now, this is the artery which is split open, and you can see this yellow fatty streak. This is how the plaque buildup starts. And how does fatty streak looks like under the microscope? This is the lumen, and this is the fatty streak, which is composed of macrophages which have gone inside the endothelium. So this is a much more advanced magnification view of fatty streaks, the macrophages inside the endothelium. And as the atherosclerosis continues to growing and these macrophages start collecting and they start building up a plaque. Now, this is the normal coronary artery, and now you can see there is a plaque built up. Can you see the plaque built up? And it has narrowed the lumen, narrowed the blood flow of the artery. So this is how the coronary artery starts getting blocked because of the fatty plaque deposition. This is under the electron microscope. You can see the lumen is now narrowed, the artery. This was the normal artery, and then now you see the lumen is now narrowed. After this, all this is plaque built up. So when the lumen is narrowed, the blood finds difficulty to flow and person starts having angina or chest pain. So these are, after macrophages, the second line of defense comes the platelets. So these platelets also, the platelet job is to form a platelet plug to prevent any bleeding. So platelets are the second line of defense against any injury. And that is the reason the platelet, they start clumping together. They clump with the fibrin, and these are the platelet and this is the fibrin mesh. And it is the clumping together of the platelets and the fibrin mesh that the clot forms. And ultimately the red blood cells also get entangled into this fibrin mesh, and they form a red clot full of red blood cells, fibrin and platelets. Now here comes you must have heard that the moment a person is getting a heart attack, the first thing we give is aspirin. Now this aspirin is not giving as a painkiller, but it is an anti-platelet agent. So to dissolve the clot. So the aspirin is to be given as early as possible, even at home. So this is how a plaque rupture, whenever the plaque rupture occurs, the blood, the circulating blood comes into contact with the underlying media, and the coagulation cascade starts. The clotting cascade starts. Now you must have heard of intrinsic pathway or extrinsic pathway. I'm not going into the detail, but ultimately what happens is thrombin is formed, and thrombin binds with fibrin. So there is a thrombin fibrin clot. So this is a coronary artery. It is split open longitudinally, and you can see this is plugged with the clot. This clot is made up of fibrin, platelets, and red blood cells. For platelets, we give antiplatelets. For fibrin, to dissolve fibrin, we give fibrinolytics. So now you see that the whole lumen of the artery is filled with a red clot. So this is the lumen, this is the microscopic evidence of how an artery looks like when there is a heart attack. There is no lumen left. It's all plugged with clot. So if you see here that with each passing minute, this is the endocardium, this is the heart muscle. We have cut the heart muscle, and you can see this is the ischemia, the heart muscle getting damaged. So with each passing minute, you can see if we don't open the artery, the heart muscle damage from inside outside. So that is why that we should be opening the artery within 1 or 2 hours of starting the chest pain. After 4 hours of delay, the heart muscle gets irreversibly damaged. So there is no point of opening the artery after 4 hours. So this is a comparison. This is an open lumen and this is the closed lumen. So ladies and gentlemen, this is how an ST elevation MI differs from the non-ST elevation MI. And this is the pathophysiology of that. So the moment a person is having signs and symptoms of acute coronary syndrome, he should be taken immediately to the nearest hospital, and not any hospital. He should be taken to the nearest heart hospital, because heart hospitals are equipped with medicines, as well as they have a cath lab to open the heart clogged artery by immediate balloon angioplasty. Once the patient is in the emergency room, he is taken to the emergency room. This is our Scotch Heart Institute emergency room. And here we have to diagnose whether this chest pain which the patient is having is because of the heart or because of anything else. Not all chest pains are heart disease. So the characteristic of chest pain of heart disease is a typical chest pain where a person holds his hand like this on the chest. If he's pointing the chest with his fingers, that if he has a pinpoint pain in the chest, that is usually not heart attack, that is usually muscular in origin. A typical sign of heart attack is the person will squeeze his chest like this with the whole palm. This is the sign of, this is called Levi's sign. This is how a heart attack patient would clutch his chest. The other causes of chest pain which should be differentiated is pulmonary embolism, or the rupture of the aortic dissection, inflammation of the esophagus, esophagitis, or even simple anxiety disorders or chest wall trauma. So for this, the role of proper history taking is very, very important. After this history taking, we have to do an ECG, 12-lead ECG, but you can see that 12-lead ECG also can be normal in about 13% of the cases. So a normal ECG should not cause that we should send the patient home. If the patient is coming with typical chest pain, then we should keep the patient admitted for at least 3 to 6 hours. During that, we should send repeated 2 to 3 ECGs and send repeated blood enzymes at 0 hour, 1 hour, or 3 hours. These blood enzymes are the cardiac biomarkers, which are the cornerstone of diagnosis of acute MI. And you can see that the release kinetics of these cardiac, there are different types of enzymes which should be sent. The CKMB, this green line is CKMB or CPKMB. Then the red line is troponin and the blue line is myoglobin. Now, earlier we used to do CKMB, but you can see CPKMB, they start within about half an hour of the chest pain and they rise within 1 hour and they gradually disappear within 6 days. While the troponins, they start within half an hour, rise within 1 or 2 hours, and they continue to be there in the circulation for about 10 to 15 days. So nowadays, we are using high sensitivity troponin for diagnosing the heart attack, acute myocardial infarction. In addition to the cardiac enzymes and ECG, we should see the echo also. We have to have an echo in the emergency room and we can see whether the heart is contracting properly or not. Is there any myocardial mitral regurgitation or is there any ventricular septal defect? These are the complications of myocardial infarction. So this was how the pathophysiology of acute MI or acute coronary syndrome occurs. So it starts with endothelial injury, macrophages build up, plaque build up, the lumen getting narrowed, then ultimately plaque ruptures, the circulating blood coming into contact with the underlying media, triggering the coagulation cascade and ultimately the clot formation. And that is when the person starts having severe chest pain and he is to be rushed to the nearest emergency ward. Now, what are the management principles for acute coronary syndrome? The general principle is that patient is having severe chest pain. So as a doctor, as a pharmacist, your aim is to relieve the pain because patient is coming to the hospital with pain. So we have to give immediate painkillers, and the most commonly given and most effective painkiller is opioid analgesic, which is morphine sulfate. So morphine should be given 1 to 2 milligrams intravenously. We have to immediately take a venous access. We have to start monitoring because these patients can have arrhythmias, cardiac arrhythmias. They can have very fast heart rate, they can have very slow heart rate, and they should be admitted. Simultaneously, as I told you, that the cause of acute coronary syndrome is the clot formation, and the clot is built up of antiplatelet agents, built up of platelets, fibrin, and red blood cells. So our aim is to reduce this clot by giving antiplatelets and anti-fibrin agents. So let me now take you in detail the treatment. The first thing is the person is having breathlessness. He may be having reduced blood supply, oxygenation because of heart attack. So you should put the patient on oxygen. If the SpO2, everybody now knows what is saturation of, because of the COVID era, everybody now has a pulse oximeter at home. If the saturation pulse on the pulse oximeter is less than 90%, then that person should be given an oxygen in the emergency room. Then, so the guidelines say that oxygen is indicated if the saturation is less than 90%. We should not give oxygen in all the patient. If the saturation is more than 90%, we should not give oxygen. Then, as I told you, that the moment patient comes, or even at home, you should give him an aspirin, a full aspirin dissolved in half glass of water, because this aspirin is an antiplatelet agent. It blocks the formation of thromboxane A2 and thus it prevents the platelet plugging, platelet aggregation. So the first drug of choice in acute coronary syndrome is aspirin. So all households in your home, you should keep an aspirin at home. Many times people ask that what medicine I should be giving if I am suspecting somebody having a heart attack. So the medicine which we have to keep is a dispersible aspirin, and this should be given in half glass of water. Second comes the Plavix or clopidogrel. Now this is also an antiplatelet agent, and this is a P2Y12 inhibitor, which is a ADP receptor, which is there on the surface of the platelets. So that also, if we block the P2Y12 receptor on the surface of the platelets, so that also prevents the platelet plugging. So aspirin acts by blocking the thromboxane A2, while clopidogrel or Plavix acts by blocking the P2Y12. So there are two different pathways of blocking platelets. So this is the importance that the important role platelets play in the generation of acute coronary syndrome. So we have to block platelets by any means, by giving aspirin or by giving clopidogrel. Now, in addition to clopidogrel, there are different other P2Y12 inhibitors like prasugrel, which is another P2Y12 inhibitor, or ticagrelor, which comes with the name of Brilinta. So, but these are very, very powerful antiplatelet agents. Having given the antiplatelet agents aspirin and clopidogrel or ticagrelor, our aim is to reduce the patient's blood pressure and reduce the patient's heart rate, because higher the blood pressure, higher the heart rate, more is the oxygen requirement of the heart. Our aim at that time is, because the myocardium is ischemic, our aim is to reduce that ischemia by any means. So after giving oxygen antiplatelet agents, the next agent is we should give a beta blocker, provided there are no contraindications of beta blocker. What are the contraindications of beta blocker? Severe asthma or high grade AV blocks like type 2 second degree block or congenital complete heart block, or a patient is having severe COPD, then we should not give a beta blocker. So what is the dose of aspirin? We should give a 300 milligram dose of aspirin. What is the dose of clopidogrel? Again, a loading dose of 300 milligram is given. What is the dose of prasugrel, which is an antiplatelet? The dose of prasugrel is 10 milligrams, but it is loaded with 60 milligrams. What is the dose of ticagrelor, another antiplatelet? The dose of ticagrelor is 180 milligrams. So, as I told you about the beta blockers block the catecholamine surge, and they reduce the myocardial oxygen demand by reducing heart rate, reducing blood pressure, and controlling the contractility. So they just reduce the incidence of primary ventricular fibrillation, which is one of the cause of sudden cardiac death. Now, you also must have heard of sorbitrate. And most of the time you think that the moment person is having heart attack, you should give sorbitrate at home. Now, sorbitrate should not be given at home, because sorbitrate is a venodilator and dilates the coronary artery. And when it dilates, it can cause sudden fall in blood pressure. So Nitroglycerin is to be given when the person is in the hospital because it can cause sudden fall in blood pressure. So sorbitrate should not be given at home. This is what I wanted to convey. This is very important. I earlier told you that for pain relief, you have to give the most powerful pain reliever, which is morphine, which is an opioid. You people must be knowing more than me about morphines. It reduces the pain of ischemia and anxiety. It has an indirect effect on catecholamines. It also may dilate the coronary artery and reduce preload, decreasing the myocardial oxygen demand. Then comes the anticoagulants. Now I told you that the coagulation cascade, the clot is a combination of platelets, fibrin and red blood cells. So for platelets, we have given aspirin and ticagrelor or Plavix. For fibrin, we have to give, fibrin is formed because of the thrombin which acts on fibrinogen and converts it to thrombin, to fibrin. So we have to block the thrombin. So heparin basically is an indirect thrombin inhibitor by binding to the antithrombin. So we should give intravenous heparin, either unfractionated heparin or nowadays low molecular weight heparin are also available, like enoxaparin, dalteparin. Again, you people must be knowing much more than me. Another form of anticoagulation are direct thrombin inhibitors like bivalirudine. Bivalirudine is another, but we should not combine these two together. Either we should give heparin or we should give bivalirudine. Then there were 2B3, what is the dose of heparin? The dose of heparin is 70 to 100 international unit per kg intravenous bolus. The dose of enoxaparin, which is low molecular weight heparin, is 0.5 milligram per kg intravenous bolus. Likewise, dose of direct thrombin inhibitor bivalirudine is 0.75 milligram per kg IV bolus. Then comes the 2B3A inhibitors. You must have heard about abciximab or tirofiban or aptifibetide. These three are 2B3A inhibitors, and they act on the final common pathway of the platelet aggregation. They were used earlier, but nowadays they have a very limited role, and we no longer use these 2B3A inhibitors. So 2B3A inhibitors should be considered for bailout if there is evidence of no reflow or a thrombotic complication on the cath lab. So this is not to be given in the emergency room. After 2B3A inhibitors, now we have to now reduce the afterload of the heart, reduce the blood pressure of heart. First thing, we have given a beta blocker. Then we should give an ACE inhibitor. The commonest ACE inhibitor we give is either enalapril or ramipril. So the dose is about 2.5 milligrams or 5 milligrams once a day. We can also give angiotensin receptor blocker, telmisartan or olmesartan. But the commonest we should use is an ACE inhibitor, angiotensin converting enzyme inhibitor, either ramipril or enalapril. Ramipril or enalapril, they reduce the peripheral vasoconstriction and reduces the blood pressure. So they are very helpful. So ACE inhibitor, the recommendation, what are the recommendations? These are basically the European Society of Cardiology guidelines, which I am showing you. And this green means class 1 indication. Class 1 indication means they are recommended. So the angiotensin converting enzyme inhibitors are recommended starting with within the first day of ST elevation MI. Then comes the aldosterone blockers like spironolactone, eplerenone. They also have a role in the acute management of myocardial infarction as they reduce fibrosis and They are beneficial in high risk post-MI patients. Then we have to give statins also, like either atorvastatin or rosuvastatin. They basically reduce the LDL and they may reduce the inflammation also. The starting dose of atorvastatin is 80 milligram once a day in the acute stage and then maintained. And our aim is to keep the LDL, the low density lipoprotein, less than 55 milligrams in patients who have already got a heart attack. If in place of atorvastatin, we can also give rosuvastatin. The loading dose is 40 milligrams per day. So these are the European guidelines which say it's a class 1 indication. It is recommended to start high intensity statin therapy as early as possible. So, ladies and gentlemen, this is the workflow this is the flow chart of how you treat a patient of acute coronary syndrome. And you can see that this is the clock ticking. This is the timeline. And you can see that as the moment chest pain occurs, the patient should be transferred to a heart hospital. Now in the heart hospital, he should be transferred within 2 hours or within 120 minutes of chest pain onset. Because as I shown you earlier, if we delay in opening the artery, then there is a irreversible damage to the heart's muscle myocardium. And the upper limit of that is 2 hours or 120 minutes. We can open the clot by 2 means. Either we can give fibrinolytic agents or we can do it by balloon angioplasty. Balloon angioplasty is called primary PCI, which Kapil Dev has undergone yesterday at our hospital. So, and the recommendation is that within 2 hours of chest pain onset, we should open the artery by putting a balloon and putting a stent. If there is a delay, suppose person is in village, a person is far off, there is no hospital which is equipped to do angioplasty within 2 hours, which is a common scenario in India, then you should not wait. You should administer a thrombolytic agents. Now, what are the different thrombolytic agents? The thrombolytic agents are either streptokinase, but again, this is a very non-fibrin specific. So we no longer use streptokinase. Earlier, the streptokinase was available, urokinase was available, but we no longer use streptokinase or urokinase. What we use is tissue plasminogen activator, TPA, which comes with a brand name of Actylise. In place of TPA, there are other fibrinolytic agents which are called tenecteplase. Tenecteplase is given as a bolus dose, single bolus dose. Another fibrinolytic is retiplase. So this you must understand that though the treatment of choice is primary angioplasty or a stent, but if it is not available within 2 hours of chest pain, then we should give the patient fibrinolysis. Either we can even start in the ambulance. In the Western countries, they start this even at home. So you must know what are the different types of fibrinolytic agents available: urokinase, streptokinase, TPA, Actylise, or retiplase. So this is how the workflow of an acute coronary syndrome is followed. And this is the only disease in medicine where time is of great importance. We rather say that it's a golden hour. If the patient is thrombolized within golden hour, then the chances of myocardial heart muscle damage is the least. So, ladies and gentlemen, this was what I wanted to tell you about acute coronary syndromes, and I would be happy to answer any questions. This is my email address, my mobile number, Twitter handle, and my website. You can, if you have any questions, you can send me the mails. I can respond whenever I get time. So Aishwarya, over to you. If you have any questions, if the attendees have any questions, they can ask me. I can respond one by one.
Thank you, sir. It was indeed a very knowledgeable session. We will now move forward to the question and answer session. The first question we have is, COVID plus patients undergoing invasive ACS have high risk of cardiogenic shock. How should that be managed?
Can you speak loudly? Please speak loudly. I'm not able to hear.
Am I audible now?
Very faint. Your
Hello?
voice is faint.
Sir, am I audible, sir?
Yeah, now it is better. Yeah.
Yes, sir. Sir, I'll take up the questions. COVID positive patients undergoing an invasive ACS have a high risk of cardiogenic shock. How is the management done in such a case?
So, who has asked this question?
Sir, it is one question from a registration form, sir.
Okay, fine. So, I'm glad that somebody has asked this question. This is a very important question, and we are facing it every day because now the COVID patients are there all around us. So COVID patients, basically, we have to understand how the coronavirus affects the heart. Now, coronavirus affects the heart in multiple ways. One is it directly invades the myocardium, the heart muscle. It causes myocarditis. Second, it injures the endothelial lining. And I told you the moment endothelial lining is injured, the coagulation cascade is generated, triggered, and there is a clot formation. So in COVID patients, even heart attack incidence is also going up. And if the heart attack is not treated in time, as I told you, within 2 hours, then the heart muscle goes into irreversible damage, causing cardiogenic shock. When do we say cardiogenic shock? When the patient's blood pressure is less than 90 millimeters of mercury, then we say the patient is in cardiogenic shock, and it is a medical emergency. So if the patient is in cardiogenic shock, and if he's of COVID positive patient, then the whole staff should be wearing the protective gear, the PPE. He should be immediately taken to the cardiac catheterization lab, where to support his blood pressure, we have to give inotropic agents, norepinephrine or epinephrine or dopamine. And even we may have to put an intra-aortic balloon pump, which mechanically increases the blood pressure and supports the heart. Then we do the angiography and try to open the blocked artery. But that everything should be done under PPE coverage, because there is a risk of coronavirus to the nursing staff, to the technician, and to the doctor who is doing the angioplasty. So the difference, there is no difference in the management. The difference is only in how you protect yourself from the coronavirus.
Hello, am I audible now?
Yes, yes.
Okay, sir. Thank you. The next question we have is, when is CABG preferred over plastic?
When is?
In what conditions is CABG preferred over plastic?
Okay, so CABG, this is called CABG, it is called CABG, CABG. The full form is coronary artery bypass grafting. So the question is that in which case we do bypass surgery and in which case we do angioplasty. So it's a very, very good question and very, very commonly asked. And as a student, you must know that, because you may be asked by your relatives or friends that I have undergone an angiography, and some doctors are advising angioplasty, some are advising bypass. So what should I do? So there are 3 coronary arteries on the surface of the heart. If out of 3, 1 or 2 are blocked, then preferably we do angioplasty. If all the 3 arteries are blocked, then we should do bypass surgery, CABG. So, or if the left main artery, which is the initial part of the left side artery, then we should preferably do bypass surgery. So, but nowadays people are opting themselves for angioplasty, even in 3 vessel disease. All the 3 arteries are blocked, still they are asking for angioplasty. So nowadays very good stents are available. So we can do angioplasty even with 3 vessel disease, though the treatment of choice is bypass surgery.
So just to add on to this, does it also depend upon the percentage of the block, like the percentage of the block?
Right. So this is again a very intelligent question, that we don't open any block only when the percentage stenosis or the percentage blockage is more than 70%, 70. Only then that needs to be blocked. If that needs to be opened. If the blockage is less than 70%, suppose it is 60% or 50% or 40%, then we don't have to put a stent or do a bypass. We can give only medicines, these anti-anginals, antiplatelets, statins, beta blockers, which I have already discussed you.
Okay. Thank you, sir. The next question is, how does the therapy differ according to the choice of stent?
So there are 2 types of stents. One is a drug-eluting stent, which releases the drugs, and another is a bare metal stent. Nowadays, we don't use bare metal stents because the chances of reblockages in bare metal stents are much, much more. Even 30 to 40% of the cases come back with reblockages. So nowadays, we give only drug-eluting or medicated stents. Now, in medicated stents, it is essential that, because we are putting a foreign body inside the patient's arteries, and the body has a tendency to form a clot around the foreign body. So we have to give anti-thrombotic agents or antiplatelet agents for at least 12 months from the day of angioplasty. So in drug-eluting stents, we should give dual antiplatelet agent. One aspirin is to be given for life, and either clopidogrel or prasugrel or ticagrelor for next 12 months. After 12 months, we stop these clopidogrel or prasugrel or ticagrelor and continue the aspirin for life.
Okay. The next question is, one of our participants has asked, why does a patient experiences chest pain after plasty, and for how many days usually the pain lasts post procedure?
Right. So what is angioplasty? In angioplasty, what we are doing is we are inserting a stent inside a coronary artery. Now, whenever we are putting a foreign body and whenever we are stretching that coronary artery, there is a pain of stretch. Now, it takes about 1 day to 2 days for a body to accept that foreign body. And so in some patients, they may feel some pain for 24 to 48 hours, and then gradually it disappears. So that is the reason commonly patients may feel some pain after an angioplasty or a stent placement.
Okay. The next question is, sir, please give some insights on repurposing cardiovascular drugs for serious mental illnesses.
So this is, I couldn't understand that. What type of mental illnesses are treated by cardiac drugs? I'm not aware of that. He has to,
So
whoever has
maybe
asked,
the
he should ask.
yeah, maybe the participant wants to know about translational use of cardiovascular drugs in mental illnesses.
You give me an example, like I'm not aware of that.
We'll give the example of the participant response and have any specific drug in mind.
Yeah, so whoever has asked this question, because to my knowledge, there is no cross connection between mental health and cardiovascular drugs. We don't give cardiovascular drugs for somebody suffering.
Beta blockers are used in certain mental illnesses.
The beta blockers are basically contraindicated in depression. Beta blockers are given in anxiety. Yes, so you can say that beta blocker in anxiety, we can give beta blocker. We give propranolol. That's the only cardiac drug I can think of.
Okay, sir. We'll move on to next question. The next question is, in diagnosis, ST elevated MI shows negative stress test, while NST elevated MI, non-ST elevated MI shows positive stress test. Why does ST elevated MI shows negative stress test?
No, this is whoever has given you this information is totally wrong. There is no relation of positivity of stress test with ST elevation MI. In ST elevation MI, we don't stress the patient. It's contraindicated. If a person is having ST elevation MI, we don't put him on a stress test. Rather, there is no correlation of positivity or negativity of stress test with either non-ST elevation MI or ST elevation MI. Stress test only shows us that during exertion, the person's ECG is abnormal. Why? Because during exertion, the person's myocardial oxygen demand is going up, but because of the blocked arteries, the blood supply and oxygen is not getting fulfilled. So, and that is reflected on the ECG in form of ST depression. So TMT, treadmill test, is not specific to either ST elevation MI or non-ST elevation. There is no relation actually. This is again a wrong question, whoever has asked.
Okay, sir. What are the chances of reocclusion of the stents? And what is the further mode of treatment for reoccluded stents? Is there any medication or procedure for it?
Yes. So the reocclusion can be either acute, which can occur even on the cath table. The moment we put the stent, there is a clot formation, or it can happen within 24 hours, or it can happen within 1 month, or even it can happen very late. This is called very late stent thrombosis. Now, this is one. Another is not because the blockage can occur, not because of the clot formation, but because of, again, the rebuild up of plaque formation. There is a difference between plaque and clot. Plaque is the slow deposition of the atherosclerotic material, smooth muscle hypertrophy, endothelial hypertrophy, that is plaque. While clot is sudden occlusion of the artery. So the stent can get blocked suddenly, or it can get blocked gradually. The chances of stent getting blocked suddenly are very, very low because of the technique involved. And that is the reason that you should get a stenting done by experienced operators and experienced good centers. Now, stentings are done nowadays in remote villages, but the type of the quality of stent, the experience of the doctor, that all matters into whether what will be the ultimate outcome of the stents. That is the reason, to prevent this clot forming, we have to give dual antiplatelet agents at least for 12 months. To prevent restenosis for plaque buildup, we have to give high dose statins for almost whole life. So by giving antiplatelet agents and by giving statins, we can prevent or reduce the risk of stent getting blocked.
Yes, sir. Sir, we have a few more questions. Is it okay if we take those up?
Yeah, you can. You can.
Okay. The next question from a participant is, can using colchicine for CAD improve cardiovascular outcomes?
A very, very good question. Now, recently, colchicine 0.5 milligrams has been shown. There is a trial called COLCOT trial, COLCOT, COLCOT trial, in which they have given 0.5 milligrams of colchicine to heart attack patients, and they have found that it reduces the mortality, it reduces the infarction size. So yes, colchicine is now being given as an acute management of heart attacks. I am very glad that you have asked this question, because people usually forget giving colchicine. Colchicine is basically an anti-inflammatory agent.
Yes, sir. The next question we have is a comparative one where the patient wants to know comparison between thrombolysis versus only plasty, or plasty plus thrombolysis versus thrombolysis and plasty.
Right. So he meant to say that when should we do thrombolysis, when should we do plasty?
Plasty.
As I told you that if the patient can be, if he is in a position that we can open the artery within 2 hours, then he should, and he has access to those hospitals where angioplasty can be done, because angioplasty cannot be done in remote villages or small towns, then we should do plus he should be able to afford it also. It's an expensive procedure. Then we should do angioplasty. The gold standard for opening artery is angioplasty. If there is a delay of more than 2 hours, then we should give a thrombolytic agents. Now, but thrombolytic agents are not 100% successful. They can open artery up to only 70 to 80% chances. 20 to 30% times they may fail. So if they fail, if there is a failed thrombolysis, then after thrombolysis, we can still shift the patient to the hospital where cath lab facilities are available, and we can open the artery. So this is angioplasty after thrombolysis. So this is called failed thrombolysis followed by angioplasty. There is another term which he called, he has asked, is thrombolysis and plasty. Now this is called, this is a term called facilitated angioplasty. Means there was some delay which was anticipated, so the patient has been given thrombolysis either in the ambulance to start dissolving the clot, and on arrival in the cath lab in the hospital, he's given a stent. So this is called facilitated angioplasty.
Okay. So the next question we have from a participant is, sir, can you please explain this sentence? The sentence goes as, an electrocardiogram revealed diffuse convex ST segment elevation in leads 1, 2, 3, AVE and V5-6 with PR depression and reciprocal changes in lead AVR.
Yeah, so this shows that the convex ST elevation in the anterior chest leads PR depression. So this is, and there is an ST elevation in AVR. So this is basically an ECG signifying ST elevation MI, atrial infarct because of the PR depression, and the ST segment elevation in AVR means the site of blockage could be a left main artery. So this is basically a very, very serious type of ECG. The patient should be immediately shifted to a major heart center, and he should be immediately taken to the cath lab, and artery should be opened.
Okay. The next question is, how can we start the therapy at home if the pain has exceeded 2 hours? Can you enlighten us on the steps?
Right. So, as I told you earlier, if the pain is, first of all, you, after listening to this, you should try not to waste time. You should immediately, if you are suspecting a person having heart attack with this crushing chest pain, he should be immediately shifted to the nearest heart hospital. But in India, sometimes it happens commonly that person doesn't want to go to the hospital, especially in these COVID times, and they waste a lot of time at home. If more than 2 hours have passed at home, so you have to give first, you have to repeat those steps. You have to give a dispersible full aspirin dissolved in half glass of water as an antiplatelet agent. If there is a statin available, you have to give 80 milligrams of statin. If there is a beta blocker available, then you can give about 50 milligrams of beta blocker. But again, all these require monitoring, the blood pressure monitoring, the rhythm monitoring. The best is that after giving aspirin and statin, you should shift the patient immediately to the nearest heart hospital. Beyond that, you should not self-medicate the person at home, because your aim is to open the artery. Artery cannot be opened by just giving statins or beta blockers. You have to give thrombolytics. You have to do an angioplasty, which cannot be done at home.
Definitely.
Thank you, sir. That was the last question for this session. With this, we end the question and answer session. Now I request my teammate to take over the session.
Thank you, Yamini. Here we come to the end of our session. I, on behalf of Pharm D Community, thank our speaker, Dr. Nishith Chandra sir,
Vaishnavi, you are not audible. Vaishnavi? Myself, Aishwarya Nair, on behalf of the Pharm D community, thank Dr. Nishith Chandra sir for his marvelous and enlightening presentation. All of us gained immense knowledge through this session, and I'm sure this will be useful for all the PharmDs and medical students. On behalf of the whole PharmD community and all the participants, I once again thank our speaker for today. During such difficult times of COVID-19, you've taken out time and you've delivered such a wonderful and informative session. Lastly, I'd like to thank all my participants who have taken out time and have attended this session. So thank you everybody, and hope these series of webinar help everyone during their hospital postings. Thank you so much.
So thank you, Aishwarya. Thank you for hosting me. And I also want to communicate that there are lots of questions must be arising in the attendee's mind. So you can send me a mail on this address, drchandra@hotmail.com. And Aishwarya, I have also prepared a podcast in which all these questions are about angiography, angioplasty are answered. So I would request you to share the link of the podcast with all the attendees, so that they can listen to that podcast, and they can they can get the answers to their questions. Okay?
Yes, sure, sir. Sir, like, can you please share the link of the podcast to my
Yes,
WhatsApp
I'll be
number?
sharing
I'll
it
share
in
it
your
on all the
WhatsApp.
groups.
Yeah. Okay.
Yeah,
So
sure, sir. Thank you so much, sir.
Thank you very much. And Aishwarya, bye-bye.
Bye, sir.